Well, that's not good. Good afternoon. It's a pleasure to welcome everyone to the May 4th, 2026 briefing of the Forsyth County Board of Commissioners. And this briefing is for our meeting on Thursday, May 7th at 2 p.m. We do not have any discussion items today, but we do have a closed session after the meeting today. So I'm very pleased to turn this meeting over to our county manager.
Thank you, Mr. Chair, and good afternoon, Commissioners, staff, and guests. Agenda item number 1 is a public hearing on the zoning petition of Pofftown Baptist Church from RS20 to IP. Chris Murphy, our planning director, will brief this item.
Good afternoon. This is case F-1668, and it is a request of Pofftown Baptist Church to rezone an almost 6-acre tract of land west of Transu Road and southwest of Bethania Road and Ronalda Road from RS9 to IP, Institutional Public. This is the subject property shown on the Forward 2045 Growth Management Area Plan. It is located on the edge of GMA 4 and GMA 5. This is the subject property highlighted in yellow, again on the west side of Transu and just adjacent to the western leg of the Northern Beltway right-of-way. Subject property outlined in yellow on the county-wide aerial imagery. You see the overlay for the Beltway to the west. This is an existing church campus. This is the subject property on the West Suburban Area Plan update. A portion of the property is already IP as far as the recommended land use. The vacant piece of property is identified as low-intensity single-family residential. But since this is all in one ownership, staff does feel it appropriate to be rezoned to institutional and public. This is looking west along Transu Road into the subject property. Again, you see the 3 buildings there for the existing church. This is looking east along Transu Road. Subject property is to the west. So this is looking across the road from the subject property. This is looking north along Transu Road. The subject property is to the left. And this is looking south along Transu Road. The subject property is to the right. You see the zoning sign in the image. The request is consistent with the recommendations of the West Suburban Area Plan Update and Forward 2045. There are no anticipated traffic impacts associated with this request. The proposed district is compatible with the existing institution and the surrounding land use pattern. IP is an acceptable zoning district in residential settings. This was heard by the Planning Board at their March 12, 2026 public hearing. There were no speakers in opposition, and following the public hearing, the Planning Board did vote unanimously to recommend approval of this request. And with that, I'm glad to answer any questions.
Any questions for Chris?
How large is the sign?
I do not know. It will meet the requirements of the ordinance whenever it comes through, but yes, I'm sure. Of course, you have to take the full gamut of uses allowed in IP, but I'm sure this is probably being done for an electronic message board sign.
Of a religious nature?
Yes.
Thank you.
Other questions for Chris?
Okay. Agenda item number 2 is Chris's as well. It's a public hearing on a text amendment proposed by Planning and Development Services staff modifying Chapter 8 of the Unified Development Ordinances to remove Section 8.4.6.b, graded slopes, mechanically stabilized slopes, and fills from the City of Winston-Salem and Forsyth County Ordinance.
Good afternoon again. Yes, this is UDO CC 32, and it is a request to remove graded slopes, mechanically stabilized slopes, and fills, more commonly referred to as retaining walls, from the UDO. Planning and Development Services staff received a request from the Assistant City Manager for Public Works of the City of Winston-Salem to review the current approval process for mechanically stabilized slopes. Current regulations allow walls and wall sections of up to 10 feet in height to to be approved by erosion control staff. Walls exceeding 10 feet in height are subject to an alternative compliance process. In the city, approvals for excess height are reviewed by the Assistant City Manager for Public Works. In unincorporated Forsyth County, that review is handled by the Planning Board. And the Planning Board certainly isn't qualified to review those. They're not engineers. And in this case, the Assistant City Manager for Public Works isn't an engineer either, and there is no criteria by which this is to be reviewed. Although the requirements for mechanically stabilized slopes are contained in the UDO, planning staff itself is not responsible for the review or approval. In Winston-Salem, that's handled by erosion control staff, and in unincorporated Forsyth County, that's handled for DOT if it's adjacent to the right-of-way, erosion control staff for walls outside of the state right-of-way, and then sometimes city-county utilities review retaining walls in or adjacent to their assets and adjacent to their easements. Most of Winston-Salem's peer communities do not include height limits or other technical details related to retaining walls and stabilized slopes in their UDO. Staff believes that our standards for retaining walls should not include specific height limits, but should instead allow project engineers flexibility based on project specifics. Public works staff, including erosion control and utility staff, will be developing new IDS standards, which are regulations for retaining walls based on this direction. And that's included in those standards. And whenever something is submitted, whether it be in the city or the county, and it's going through utility review and erosion control review, those would be reviewed by those respective departments by this document. Anything that would go to NCDOT would be handled outside of this process. So that's why it's going into that IDS standard manual, because of our erosion control staff, which is city county, and utility staff, which is city county, are part of the reviewing agencies for that. In summary, mechanically stabilized slope guidelines would be moved out of the UDO to the IDS, which contain the technical specs for similar type of infrastructure. Staff believes that the proposed change provides a more streamlined process in which design elements will be reviewed by an interdepartmental team of public works staff with engineering and technical expertise. Again, NCDOT would be responsible for their own review and approvals of any walls necessary within their rights of way. The Planning Board unanimously recommended approval at their January 8th, 2026 public hearing, and City Council adopted this in the city on March 23rd of 2026. I do have one other note. Just know that if a retaining wall is on private property, it goes through this review, but it also has to go through a permitting review. So they have to get a permit through the inspections division, and then the engineer that sealed that drawing certifies that it was constructed per the design plan. So there are some checks and balances in this process as well, but the UDO is not the proper place for retaining wall height limitations. And with that, I'm glad to answer any questions.
Any questions for Chris?
I did have one thing that I thought of since our previous discussion. Was the 10-foot cutoff possibly related to danger of collapse during construction?
I believe it was probably related to that, and also some step back provisions. But, you know, that was a different time. That was, I want to say those standards were probably put in there 25 or 30 years ago. But I believe that is why those limits were put in there. But again, there's an exception process whereby folks can get an approval, and the folks that are approving it don't have the expertise to approve it or deny it. So that's why we're thinking it's better to just allow this to live in the engineering world and take it out of local land use policy.
Yeah, I do have some concern about it's with trenches normally, not with walls, but that's a danger point for workplace accidents.
Well, and again, this does not, retaining walls in and of themselves I mean, you still have OSHA standards, still have other things dealing with construction. So if you're in a confined space and you're doing sewer line work or water line work, you have to have trench boxes and other kind of things. This has nothing to do with that. So as far as workplace safety, if you're down in confined spaces, which if you're laying pipe below ground would be considered that's not part of what this text amendment is aimed to do. This is truly just looking at retaining walls that are above grade and getting rid of the height max and allowing the engineers to certify and stand behind their design.
Thank you.
Other questions? All right, thank you.
Agenda item number 3 is Chris's as well. It's a public hearing on an ordinance amendment proposed by Forsyth County modifying Chapter 6 and 11 of the Unified Development Ordinances to add view corridors for off-premise ground signs along segments of US 158 and US 421.
Good afternoon again. This is UDO CC 33. We've had a bi-monthly session on this. It was in one of my updates back in the fall, asking about the potential to add these view corridors in response to a request that we had along 421 about 18 months to 2 years ago. The request is to add view corridors to prohibit off-premises ground signs along segments of US 421 and US 158 within unincorporated Forsyth County and include an updated definition describing the national highway system in the UDO. As a little bit of background, the Highway Beautification Act of 1965 gives federal government the right to allow billboards on zoned or unzoned commercial and industrial areas along any road within the national highway system. The act also gives states and local governments the ability to enact standards limiting where billboards can be placed. This is the National Highway System map for Forsyth County. It is, as of 2026, all the roads identified on this map are within the National Highway System. In unincorporated Forsyth County, billboards are presently allowed only along roads in the National Highway System and that are zoned, where the property is zoned general use highway business, and then all industrial zoning, so GI, CI, and LI. Some of the roads in the National Highway System are prohibited by local regulations since they have been locally designated as view corridors as permitted by the Act. These are the existing view corridors, and I'm not going to name all those different letters, but the colors that show up on the map are the view corridors as currently exist in Winston-Salem and Forsyth County. The proposed UDO amendment resulted from a rezoning request for a billboard which was denied by the county commissioners back in 2024. Staff reviewed the National Highway System map and the view corridor map and determined that US 421, US 158, and NC 109 in unincorporated Forsyth County were not protected from the placement of billboards in the UDO. Staff began researching the inclusion of these roads in the view corridor program. I brought that before you earlier this year, and there was a desire to have a view corridor text amendment brought forward for 421 and US 158, but there was not consensus about NC 109, so that was removed from consideration in early 2026. This is the proposed view corridor map. The view corridors that would be added are adding this section of view corridor M along US 421 and view corridor P along 158 in between Winston-Salem and Walkertown, and then on the other side of Walkertown to the county line. We did check with Walkertown, and they were interested in that section P being added as part of this. They had no qualms about that. There are presently no billboards located on the proposed US 421 or the US 158 view corridors as proposed. Staff did find 3 properties at the northeast corner of US 421 and Cyrus Ferry Road interchange, which are zoned highway business, which would allow a billboard. Under the general statutes dealing with down zoning, those 3 properties specifically need to be exempted from this view corridor adoption if the commissioners decide to do it. And we have noted that within the view corridor itself, which 3 parcels those are. So the view corridors, if adopted, would be for those entire corridors minus those 3 properties. This UDO amendment will help preserve the rural residential character along these sections of both US 421 and 158. This was heard by the Planning Board at their March 12th, 2026 public hearing. There were no speakers in opposition, and following the public hearing, the Planning Board did vote unanimously to recommend approval. I will just show this. This is these are the parcels, this parcel, this parcel, and this parcel. These are the 3 parcels that are exempted from the view corridor for 421, corridor M, should you decide to adopt it. And with that, I'm available to answer any questions.
Questions for Chris? Thank you.
We have several special resolutions, and individuals and organizations will be here on Thursday to receive them. Agenda item number 4 is a proclamation recognizing May 14th as Childhood Apraxia of Speech Awareness Day in Forsyth County. Agenda item number 5 is a proclamation recognizing May as Huntington's Disease Awareness Month. Agenda item number 6 is a proclamation recognizing May as National Tennis Month. Agenda item number 7, is a resolution recognizing May as Eligibility Specialist Appreciation Month. Agenda item number 8 is a resolution recognizing May as Mental Health Awareness Month. And agenda item number 9 is a resolution recognizing May 3rd through 9th as Professional Clerks Week. Agenda item number 10 is a resolution revising dates for the authorized open display and discharge of firearms at Triad Park under limited circumstances and with the concurrence of Guilford County. Chris Weevil, our Parks Director, will brief this item.
Good afternoon, Commissioners and staff. The item that I bring to you today is a resolution that will allow the authorized open display and discharge of firearms under limited circumstances at the Carolina Field of Honor at Triad Park annually on Memorial Day, the last Monday of May, and Veterans Day, November 11th. The discharge of firearms being referred to are for ceremonial 21-gun salutes with weapons modified only to discharge blanks. On March 17th, 2022, the Forsyth County Board of Commissioners adopted a resolution authorizing the open display and discharge of firearms at Triad Park under limited circumstances with the concurrence of Guilford County that granted permission for the open display and discharge of firearms at the Carolina Field of Honor on Veterans Day, November 11th, and Vietnam Veterans Memorial Day on March 29th. As the War Memorial Foundation only holds 2 formal ceremonial events annually, one on Veterans Day and the other on Memorial Day, they have requested to substitute Memorial Day for Vietnam Veterans Memorial Day as an approved day to allow the open display and discharge of specially modified firearms at the Carolina Field of Honor. The resolution will allow specially modified firearms to be openly displayed and discharged with the written concurrence of Guilford County's Parks and Recreation Director and Forsyth County's Parks and Recreation Director with the following conditions. Only on the premises of the Carolina Field of Honor, only on Veterans Day, November 11th annually, and Memorial Day, the last Monday of May annually, only with weapons modified specially to discharge blanks, only after signs have been posted at the park entrance indicating a military ceremony with the open display of discharged specially modified firearms and blanks is taking place, and only when conducted by officers and enlisted personnel of the Armed Forces of the United States when acting in the discharge of their official duties, civil officers of the United States when acting in the discharge of their official duties, officers and soldiers of the National Guard when called into actual service, and persons or organizations within Forsyth counties and Guilford counties with written sanction to conduct an event involving the open display and discharge of specially modified firearms under the supervision of Forsyth or Guilford County law enforcement. And with that, I'd be happy to answer any questions.
Any questions for Chris? Thank you.
Agenda item number 12 is a resolution authorizing changes to the county's health and dental plans and county-paid basic life insurance for disability retirees. Shannon Hutchins, our Human Resources Director, will brief this item.
Good afternoon, Commissioners. This resolution authorizes updates to the county's health plan and dental plan, as well as changes to the county-paid basic life insurance for disability retirees. The county's health and dental plans are funded through shared premiums and claim cost between employees and the county's internal services fund. For the past 2 fiscal years, the health plan expenses have exceeded plan revenues. In fiscal year 2026, the county budgeted $30.7 million for the health plan, and without changes to the plan design, costs are projected to rise to $39.2 million in fiscal year 2027. To help stabilize the plan and reduce the rate of cost growth, the county manager and human resources director recommend introducing an enhanced health plan option with a lower deductible, as well as a basic option with a higher deductible and lower premium. The recommendations also include adding a 4th prescription drug coverage tier and removing coverage for GLP-1 medications prescribed for weight loss only. Additionally, the county manager and human resources director recommend transitioning the dental plan from a self-insured plan to a fully insured model and offering 2 options for employees, also an enhanced plan with expanded coverage and a basic plan that reflects the current plan design. The county also provides life insurance to disability retirees at no cost to the retiree. Premiums for this benefit have increased by more than 1,100% since fiscal year 2024, resulting in an additional annual county cost of $132,000. To address this increase, it is recommended that the county-paid basic life insurance for disability retirees be discontinued for individuals retiring on or after July 1st, 2026. Disability retirees approved by the North Carolina Local Government Retirement System before that date will be grandfathered and continue receiving the county-paid benefit. Collectively, these recommendations will reduce financial pressure on the Internal Services Fund and are projected to slow cost increases by approximately $4 million in fiscal year 2027. Changes as described and upon authorization by the board would be effective July 1st, 2026, and I'll be happy to answer any questions.
I have one. So when you're talking about slowing the cost increase down to quote unquote almost saving $4 million, that was from a projected $9 million increase, right?
That's
30 to
correct.
39.
Yes, that's right.
So you're anticipating roughly $4 to $4.5 million increase even with these changes.
Yes.
Okay, other questions for Shannon?
What are the medications like Ozempic that are included within the purview of GLP-1?
So it's the GLP-1s for weight loss. It would be things like Zepbound, Wegovy. There may be some others out there.
Can you say those again?
Zepbound and Wegovy, and there may be some others.
Thank you.
Other questions?
Thank you.
Thank you.
I do want to jump back to agenda item number 11, which is approval of minutes for the meeting of April 16th, and those were emailed to you last week. All right, agenda item number 13 is a resolution approving a revision to the fiscal year 26 Home and Community Care Block Grant County Funding Plan for older adults and authorizing execution of necessary documents to submit the revised plan for state approval. Kyle Wolf, our budget director, will brief this item.
Good afternoon, Commissioners. This is as the county manager said, a revision of the fiscal year 25-26 Home and Community Care Block Grant funding plan based on a request from Senior Services to shift funds from various areas to increase services for home-delivered meals and in-home aid level 3 personal care. There's no change in the amount of funding. It's just really a shift of how they plan to use those funds. We have to submit this to the state upon your approval. Happy to answer any questions.
Any questions for Kyle? Thank you.
Agenda item number 14 is a resolution to direct fiscal year 27 expenditures of opioid settlement funds and an amendment to the North Carolina Opioid Settlement Special Revenue Fund to appropriate funds for fiscal year 27. Michael Duncan, our Behavioral Health Services Director, will brief this item.
Good afternoon, Chair Martin, Commissioners. Okay. So what you have in front of you today is two different resolutions. One is going to be for our opioid settlement funds. The other is going to be for our behavioral health funds, which was previously our MOE funds. Just want to go through a little bit of that and then see if you have any questions at the end. I also have our subject matter experts with me today from the Behavioral Health Services Supervisor, Amber Humble, who led the Behavioral Health Funding Review Panel, and then Annie Vasquez, who is our Substance Use Services Coordinator. And she held up the panel that went through the opioid settlement funds. All right. So the MOA with the state outlines very specific elements under the opioid settlement overview, and those funds cannot be used for general government or law enforcement efforts. Under that MOA, there's an option A and option B for the strategies. Forsyth County elected to use funds according to option B with maximizing potential strategies and opportunities. We are in the process of getting ready to relook at those strategies for the upcoming year, but for now, they still fall under the one that we have currently. Right, in front of you, you should have all of our recommendations for the funding. Like I said, this was a panel of individuals that we put together. They were subject matter experts from our behavioral health services team and also someone from Partners LME MCO, as well as someone from the HHS board. Once we came up with the recommendations for the opioid settlement, we did bring those to the HHS board, and they unanimously supported each of those on April the 1st. Unless you would just like, I will not go through each one of those because there are quite a bit, but I am happy to answer any questions that you might have on them.
I'll just make one comment. I shared it with Denise Price, is that it would be helpful to have some, I don't think it has to be done now at this point, but it's more about evaluation sort of results. You know, like we talked about various kind of deferments from emergency rooms, for example, or we're able to serve, 433 people or whatever it is, some of those kinds of things that quantify the success of these particular projects. It would just be nice to know that. And I think important for you all to know that when you evaluate these proposals, which I'm assuming you do. I'm hoping that that's a part of there's one thing about approving that's a great idea and it works and it's documented, it's well researched, whatever, but is it being implemented as designed, implemented as the best practices, and is it achieving, results and reaching the people intended to reach, I guess. And perhaps there's just some way that could be put together. If you put your sort of thinking about it, I'm not trying to create busy work. I think it should be work that people should to know to success, so that a number of times I'll get asked, I mentioned we have this opioid grant funding program. And I know the big picture part, our number of opioid deaths have declined, but relatively speaking, in other urban areas, you're looking, not exactly, it's declining, but is it declining as much, whatever, success. So it'd be nice to know that we've got, 20 programs, 25 programs of various sorts that are basically competitive, and we end up with, we've had, really kind of remarkable results, and if you want to know it, we can tell you, that kind of stuff. It'd just be nice to know more about that.
And we agree with you. A couple of things that we are doing to address that moving forward that's already underway is we do get monthly reports with the invoices that has those metrics and those outcomes to make sure that they are doing exactly what we fund them to do. We also last year, or this current cycle, have introduced site visits to where we go out and do compliance visits with each of those vendors, at least 2 per year with each of our vendors, no matter the amount of funding that we do. And then we also send back letters or correction items that we might need from them if there is any deficiencies. So that is some things that we are actively working on and have implemented this year and continuing to get better as we go.
Well, I will say this number of grants, I'm sure, I'd like to thank all the committee members who spent a lot of time going over that, and I appreciated your annotations here about, in some cases, increase because of this, decrease because of this, and I appreciate that level of attention to detail, and it's a time-consuming and difficult task.
Thank you, sir. Yeah, we appreciate that. That return on investment is very important to us as well, and making sure that we are putting the money where it needs to go and not putting it where it does not need to go.
Any other questions?
I do have a question, Chairman, and thank you for that question because that would have been one of the things that I wanted to know, and thank you for the information. Without calling out the particular organization's name, I wanted to ensure that these individuals, and I don't want to misspeak, because I know that we're doing grants in community and opioid and other areas as well. So I won't mention their name, but I want to make sure that they're able to do the work that they say they're going to do and not return the money back to us. I see a name, and we can talk about it offline. So just wanted to put that out there.
Yes. And I appreciate that. One thing that we actively do with our vendors is we are in constant communication with them. We also hold quarterly settlement for the opioid especially. Okay. We have quarterly meetings. I know Commissioner Gray has been there to those before, and we actually sit in a room with all of our vendors. It is a requirement of the grant that they come and they answer those types of questions, and also network to see how they might be able to work together to serve the bigger community.
So you're able to see how much money that they're utilizing throughout this time? Okay.
Yes, ma'am. We keep that through a spreadsheet, and I'm actually exploring a dashboard that might be public-facing moving forward. So
yes.
We are hoping and we are working to try to get that together.
Absolutely. Thank you.
Michael, how many of these are for-profit as opposed to either governmental or nonprofit entities?
I would refer that to Annie, if you know. If you don't, we can.
I don't know off the top of my head.
Yeah, we can get that information back to you.
Thank you.
One thing that I will say on that is we are very specific when we write the contracts, Annie and Amber both, to make sure that that money goes to uninsured, underinsured individuals and not for profit.
So like unit reimbursement?
Correct. Yes,
Okay.
a lot of the things are, we have moved from just funding positions to more reimbursement for services to make sure that we're not overpaying and we are only paying for services that are rendered.
Thank you.
And based on Medicaid rates.
Yes. All right. Any other questions with opioid settlement?
Good.
Agenda item number 15 is Michael's as well. It's a resolution authorizing appropriation of behavioral health funds and execution of associated agreements in fiscal year 27.
All right. And once again, thank you. And it's still good to be up here. Again, I will not go through each of these, but I will tell you that Amber has done a really good job. We put together a very similar panel with some different individuals, but still that same makeup with an HHS board member, one of our partner staff, as well as county staff to review those applications, to go through and make sure that where we're putting the money, again, those individuals are responsible and have turned in complete packets, et cetera. Happy to answer any questions that you might have.
Any other questions? Thank you.
Thank you.
Agenda item number 16 is an amendment to the County Capital Projects Ordinance to appropriate funding received for the Triad Park Beautification Project. Kimberly Bussey, our Deputy Budget Director, will brief this item.
Good afternoon, Commissioners. In March, Forsyth County received compensation for $180,000 from the Transcontinental Gas Pipeline Company for an easement in Triad Park. These funds will be used for a beautification project in Triad Park, but because Forsyth County and Guilford County jointly own the property, the specifics of the project needed to be agreed upon by both parties. Forsyth County met with Guilford County last week, and they've decided on some projects to improve existing park facilities, some new roof for a shelter, and for a park office, some HVAC replacement projects, some restroom renovation projects, and some paving for the parks. So that's been agreed upon. This item is necessary to appropriate this funding to the county CPO, and I'm happy to answer any questions you might have.
Questions for Kimberly? Thank you.
Agenda item number 17 is, I thought Kimberly's as well, maybe not. It's a resolution approving a first revision to the fiscal year 26 Juvenile Crime Prevention Council funding plan and an amendment to the fiscal year 26 budget ordinance to appropriate $3,904 from the North Carolina Department of Public Safety for the JCPC.
It is my item, yes, thank you. Our numbers are different, but I'm here. Thank you. So in February of 2026, the Forsyth County Juvenile Crime Prevention Council, or JCPC, received $3,904 in discretionary funds from the North Carolina Department of Public Safety. During their March meeting, the JCPC voted to allocate this additional funding plus a $15,000 reversion from the YWCA Teen Court Program. Triad Restorative Justice will receive an additional $10,540. Family Services will receive an additional $8,364. This item is necessary to appropriate that additional $3,904 received from the state and to get the revised funding plan for the JCPC approved by you all so we can submit back to the state for approval. And I'm happy to answer any questions you might have on this item.
I just say appreciation that it looks like we're avoiding reversions on JCPC issues.
Hope so.
Making those corrections quickly and getting that done. That's great. Any other questions for Kimberly on the JCPC amendments? Okay.
I'm going to introduce 18 and 19 together, and Kimberly's going to kick us off and then transition to the Sheriff's Office. Agenda item number 18 is a resolution authorizing an amendment to the agreement with NavCare North Carolina LLC to increase the amounts allocated for off-site inmate medical services for fiscal years 26 and 27, and an amendment to the fiscal year 26 budget ordinance to appropriate fund balance to the Sheriff's Office for the increase. And then 19 is a resolution authorizing a third amendment to the agreement with Aramark Correctional Services LLC for law enforcement detention center on-site food services, and an associated amendment to the fiscal year 26 budget ordinance to appropriate fund balance to the Sheriff's Office for the increase to Aramark for jail food services.
Yes, thank you. So I just want to start by talking about the budget ordinance amendments that are associated with these two items. The Sheriff's Office Business Manager, Mr. Yance, and the NAFCARE team are here to dig deep into these issues. But before we do that, I just wanted to be clear that the fiscal year 26 adopted budget included a requested and recommended amount of budget totaling more than $10.7 million for inmate medical services and for inmate food services contracts. These services were bid out by the Sheriff's Office in 2023. The food service contract was bid in February and the inmate health in October. That means for Aramark, we're in year 3 of 3 of that contract, and for NAFCARE, we're in year 2 of 3 for that contract. The cost of both these services really depend on the average daily population at the jail, or ADP. Aramark is based on a range. It's calculated based on that cost of service and the range which we happen to be in for the time. And for NAFCARE, the Sheriff's Office based the contract not to exceed amount on an estimated or average ADP from 2 years ago. At the time, the contract was based on an ADP of about 850. I think I heard this morning it was at 917, and it's been as high as pushing 950 lately. And so a higher ADP plus higher off-site medical costs, which NAFCARE, I hope we'll talk a little more about in a minute, mean that these two contracts have some significant overages in fiscal year 26. We mentioned this briefly in one of our budget workshops. These two agenda items both include a budget ordinance amendment request to appropriate fund balance for the overage, but I just kind of wanted to give you a quick overview of the total. That's $1.02 million in fund balance for these two items. It's requested to be appropriated today for these contract overages. Could I use this? Just to give you an idea. It's $880,000 for the NAFCare overage and $140,000 for the Aramark Jail food service overages. Are there any questions for me on the fund balance appropriation requests portion? Not, I'll turn it over to Mr. Young.
Good afternoon, Chair, Vice Chair, members of the board. Today's agenda items request approval and additional funding for contract amendments with NAFCare North Carolina LLC, previously NAFCare Incorporated, and Aramark Correctional Services. These increases are needed to ensure we remain compliant with our legal requirements. As part of this request, we will provide a brief overview of our current budget status, the current medical and food service expenditures, the causes of the cost overruns, and our funding needs and potential solutions. The key takeaways are off-site medical costs are the primary driver of the budget shortfall. We are requesting an additional $880,000 to help cover medical costs for the remainder of this fiscal year. We are also experiencing a shortfall in food services due to a higher average daily population, or ADP, as Kimberly mentioned, which you will see referenced throughout the presentation. Unfortunately, these shortfalls are too large to absorb within our current remaining budget. In total, we are requesting $1,020,000 to fund these additional needs. First, I want to emphasize that both medical care and food services are legally required. We are statutorily obligated to provide necessary medical care, including off-site treatment for specialized care and emergency needs. We are also required to provide 3 meals per day to every inmate, and that failing to meet these requirements creates significant legal and financial risk to the county. An inmate's medical needs are not assessed by or determined by any of the staff at the detention center. All medical decisions are provided by NAFCare during their normal operating hours or by emergency personnel after hours. Public Health does provide some retrospective review of these cases. The total medical services budget with NAFCare for this fiscal year is just over $8.7 million. This includes on-site care at the detention center, administrative services, off-site medical treatment, which is shared 50-50 with NAFCare, and behavioral health units funded by behavioral health funds. Most services are billed at a fixed monthly rate and are on track. This includes the on-site as well as the administrative services. The exception is off-site medical charges, which are already exceeded this budget this year by $540,000. These figures reflect expenditures through March and April of 2026. Most services are billed in advance for the next month, while the off-site medical costs are variable and billed after the services occur. In this slide, we wanted to show the volume for each of the categories for the off-site medical costs. They're broken down as local, which is your like Baptist or your specialized care here in Forsyth County, Prime, and the North Carolina Department of Public Health. Local costs make up the largest portion, but this cost also covers the largest volume of inmates. Prime and the Department of Public Health relate to the Safekeeper program and involve much fewer inmates. Also, about $128,000 of the current costs in this year actually occurred in the last fiscal year, but due to processing delays, they have been expensed in this fiscal year, which is part of the budget shortfall.
Could you go back to that slide? And only just because which color, I can't see the colors well enough. So for example, what is the green piece of the pie?
So the portion that's on the right side of that is your off-site local cost. And so again, that could be Baptist Hospital here, or it could be like specialized dialysis centers here in Forsyth County. The larger portion on the left side, that is your Prime. That is off-site costs through the Safekeeper program, which we're going to discuss a little bit further. And then the small little portion is the Department of Public Health. That is the on-site per diem rate through the Safekeeper program.
Yeah, I got it now.
This slide shows the increase in off-site medical costs since last year. As you can see, we are seeing significant increases in the off-site medical invoices, including for local off-site costs. Overall, the average monthly costs have increased by 151% since last year, with local costs increasing by over 110%. Local costs includes, again, like the Baptist Hospital, specialized care providers such as dialysis centers, but do not include the Safekeeper program costs through Prime and the Department of Public Health. The annual increase calculations were based on the average invoice amounts when the invoices should have been expensed. This is to account for last year's carryover to minimize any skews that might cause. The Safekeeper program is administered by the North Carolina Department of Adult Corrections and is used for inmates who need continuous specialized care or pose a higher security risk. These inmates are primarily housed at the Central State Prison in Raleigh, but are still considered in our custody and our financial responsibility. Care provided at the prison is billed in two formats. First, on-site at per diem rate, which is shown on the invoice as the North Carolina Department of Public Health, and then off-site care, which is billed through the North Carolina Sheriff's Association Inmate Medical Cost Management Plan, and is managed through Prime Health Services and shown on the invoices as Prime. As with the local off-site medical treatment, these costs are shared 50-50 with NAFCARE. As part of the agenda item, I did include an article that came out about the Central Prison related to the Safekeeper program that also shows that, unfortunately, this situation that we're seeing is not just local. This slide right here shows the increase for the Safekeeper program cost. Prime costs have increased by 253% since last year, and the North Carolina Department of Public Health costs about 81% since last year. There are several key drivers that are contributing to these cost overruns. One, a higher average daily population to the recent passage of Arenas Law. That was back in October of 2025 when that was passed. And that was due to the young lady who was stabbed in Charlotte. In August of 2025, that bill became effective on December 1st, 2025. It targets pretrial release by restricting bail, requiring secure bonds by violent offenders, adding mental health evaluations, and enhancing sentences to keep violent offenders in custody. The second is longer lengths of stay in the detention center due to court delays and continuances and such matters as those. Number three is increased medical needs among inmates due to an overall decline in inmate health, which NAFCARE is going to highlight a little bit further. The rising healthcare cost overall, and as well as the $128,000 in the prior year expenses that were expensed in this year. This slide right here, I just wanted to provide this to kind of show the scale and the trends between the ADP at the detention center as well as the cost for the off-site medical. As you can see, we are most certainly trending higher with our ADP, but it is not to the volume of the off-site medical cost. So they are correlated, but they're not directly, it's not to the same impact or to the same level. At this time, I'd like to introduce Byron Harrison with NAFCARE, who will present their presentation and provide a little bit more analysis and additional information and context around this issue.
Good afternoon. My name is Byron Harrison. I'm with NAFCARE as Chief Operating Officer, and I want to continue the conversation. So briefly, NAFCARE is a comprehensive healthcare provider. We have been providing healthcare services to your inmate population since 2021, and as was mentioned, our current contract runs from 2024 through 2027. We have roughly 45 full-time equivalents in the jails that provide services for the patients, and as a part of that, we provide off-site services. So while we have those employees in your jail facility providing care, patients must go off-site for certain circumstances, either it be emergent care or specialty care that we simply cannot provide in the jail facility, like cardiology as an example, or we might have a patient with chest pain and we don't have the complete resources at 2 a.m. in the morning to treat chest pain and rule out a serious condition like a heart attack, and so we use emergency services. And we call these off-sites because they're leaving the facility. So what you see on the screen here is our current 2026 cost summary. It's important to note that this is a 50-50 share. So NAFCARE and the county have a shared interest both in controlling costs, but we also have a shared interest in making sure appropriate care is provided to these patients. Key cost drivers. So as was mentioned by Mr. Yance, we have an increase in ADP. We have an increase in off-site care, and he articulated that very well. They're not proportionate, right? Not only are we seeing an increase in the number of patients, but the number of off-site care events per patient is going up at the same time. So these are compounding on top of each other. We have an increase in patient acuity that I'm going to touch on. We've talked about safekeeping costs or safekeeper costs. And then I want to talk briefly about the industry. And please, you all are welcome to interrupt me on any of these slides. So first, ADP. So our average daily population is increasing. And as you can see in the table, I used years 2024 compared to our current 2026. And so we see about a 13% increase in ADP across that top row. If we fast forward to that bottom row, I want to look at the number of offsites in 2024 compared to the number already in 2026. We have 3 more months left. So you can see that is quite a staggering jump. So I think what really drives this point home, and as Mr. Yance mentioned, that last sentence here, there were 0.67 offsite visits per ADP in 2024 compared to 0.87 offsite visits per ADP in 2026. So that's that compounding effect that we see. Not only do you have more patients, but we have more offsite events per patient. Let's talk about acuity. So acuity, in the way that I'll use it today, is just how sick are these patients. If you have a highly acute patient, they are very sick. If you have a low acuity patient, they are not very sick. And so NAFCARE uses a few markers in order to measure patient acuity in correctional facilities. We measure how many patients have been diagnosed with a chronic care condition, which we must manage. We measure the number of patients that come in to the facility on a substance that we must detox them from, like alcohol or benzos. And then we also measure patients who are at risk of attempting suicide as a very clear indicator as a severe or significant mental health condition that must be treated. So we stack these up and we compare them year over year. And as you can see in this graph, our acuity of the patient population when I'm comparing the first quarter of 2024, first quarter of 2025, first quarter of 2026 is growing. And I really want to point out our chronic care conditions. So in first quarter of 2024, we had 1,232 identified chronic care patients, and now we're at 1,961. So this is everything from hypertension to asthma to chronic mental health disease, really increasing significantly. And then detox is another good indicator. Now you see that 419 to 492, at first glance that may not seem like a lot, but that really is. That means our patients coming in the door are much sicker, and detoxing patients, as was made a very clear statement to me earlier, a lot of times when patients come in on substance abuse and we are detoxing more patients, we typically find a lot of underlying conditions after they've finished their detox regimen, and we might not know right off the bat. So this patient population is at significant risk, and then as we continue to care for them through their stay, they're going to go off-site more.
So if I can ask a question to be clear, once they come into the detention center, they're being evaluated mental health?
Yes.
And they also get a physical screening? Yes. Okay, fair enough. Thank you.
Upon intake, we do a medical screening, a mental health screening, and if those indicate as there's more complex conditions, then we immediately move them to evaluations, all within those first hours of booking.
How many mid-levels do you have on site for the evening and overnight shift?
So I do have a slide on this later. Our mid-level providers are present from 8:30 to 4:30. And then we have services that support us after hours, which I'll get into, that are provided by telemedicine.
So they're not on site?
Correct. We do not have 24/7 provider coverage on site. One key item on this slide that I think is really important, that last note underneath the bar
Before you-
graphs.
I'm so sorry.
Yeah.
Before you go further, I was alarmed to hear that there's no one after 4:30. So if you have an immediate heart attack or something, is the staff trained to respond to that, or how do you handle that?
I should have been more clear. When I said provider, I meant a physician or a mid-level provider that's able to write an order. We
Okay.
absolutely have medical
All right.
staff 24/7.
Okay.
So we have nurses there.
Gotcha.
Good,
Thank you.
good point of clarification. And that nursing team is what uses our remote services in order to evaluate.
And these are RNs and LPNs?
Yes, sir.
Okay.
So that last point, 27 of the 409 patients who received off-site care in fiscal year 2026 made up 50.6% of the costs.
Wow.
That's staggering. That means these patients are not just a little sick. We have a relatively small number of patients that are very sick. So again, all kind of driving that point home. This information about Safekeeper is the same that Mr. Yance presented. I won't go back over it again, but the bar graph presents the same information. Our Safekeeper costs have gone up significantly this year. This is an area that myself, the county sheriff's office are all looking into. And what's unique about this is when we send a patient to the Safekeeper program, that program makes the decisions regarding the patient's care and utilization. So, for instance, if a provider that works for NAFCARE makes a decision that says this person needs to go see cardiology, I have a utilization management team that compares the industry average, reviews the chart, ensures that it's appropriate for this patient to go to cardiology based on community standards of care. Now, that process could be happening with Safekeepers. It probably is, but we don't have any visibility into it. So the county and NAFCARE are effectively getting this bill for off-site care as a part of Safekeepers, but we're not involved in how the decision was made. And so this is, again, an area of focus we really have to dig into because that is a significant portion of our off-site costs and that we both are sharing risk in, NAFCARE and the county.
So I don't mean to hog all the questions, but I think it's important for the community to know. What does it look like when individuals come in and they have health insurance or Medicaid? Do they utilize any of those resources during the period of their stay, or what happens with that?
Sure.
If you can answer, or someone from the Sheriff's Department.
Yeah, I'll go ahead.
Okay, sure, thank you.
So when a patient has private insurance, that is one of the questions we ask the patient upon booking. We want to capture that information. Also, NAFCARE employs an automated system that when we have a patient that goes for off-site care, it automatically queries national databases and say, hey, does Byron Harrison have Blue Cross? Does he have Aetna? And we try to utilize that. And then on top of that, we are able to utilize Medicaid when the patient is off-site for at least 24 hours.
Now, does their Medicaid end during their stay at the detention center? At what point?
Suspended.
Oh, suspended, okay.
Yep. So it will not help for care provided in the facility, but once they have been out of the facility for 24 hours, we can start leveraging that.
Fair enough, thank you.
So again, safekeeping is an area that we really jointly need to look at, again, because NAFCARE is on the hook for this too, right? We're 50-50, we're partners in this. This is effectively a pass-through cost. There's no margin built in. This is not this is straight cost from the hospital. NAFCARE pays, county pays, and so we're in this together. So if we take a step back to the industry, healthcare costs are going up. Everybody said that 1,000 times. We've heard that for the past 10 years. But some actual numbers behind that. So Medicare rates have gone up 15% across a 3-year period. And there's some data to back this up that's using your local hospitals here, and that's what the left side of this slide really utilizes, the diagnosis-related group data. These are DRGs. So there's a dollar amount assigned to DRGs. When we look at those DRGs, like Byron had a CT scan, and we looked at how much it cost 3 years ago to how much it costs today, we did that across a common number of DRGs, and we see that 15% increase. So even if I had the same number of patients, same number of offsites, I can still expect at least a 15% jump in cost simply because of these rates. The next item I wanted to look at is Forsyth an anomaly? So on the screen and the table, you can see two comparable sites, one slightly smaller, one slightly larger. And I wanted to dive into, is Forsyth an outlier? And looking at it, no. Our number of ER trips are in line between the two, and their total offsites are in line. Now you can make the case that, okay, Byron, comparable site one was about 700 ADP, Forsyth is at 900, and we're at 1,200 for comparable site number two. And you can say, well, your ER sites are slightly leaning towards comparable site two, and they really should be dead in the middle. Yeah, somebody could definitely make that case. My goal with this was, we have a weird anomaly that we're way out of line, where we're sending far too many people to the emergency room or anything like that. The other aspect of this is geography. I can look at a map and tell you where the sickest populations are across the country based on our jails across the country. And so these comparable sites I had to grab from other geographies with different demographics and different prevalences of disease that must be controlled. So all that to say, Forsyth is not an anomaly. All costs and all offsites are going up across the country, and that's what we're seeing, that this is not a localized issue.
Could you go back to that chart, Tom? I noticed the second from the bottom that we are higher than comparable site two on the other offsites. What would those include?
So those are specialty care visits, things like cardiology or physical therapy or dialysis. And one thing that can really throw that off is a single patient, since these numbers are relatively low, a single patient might have 4 cardiology visit follow-ups versus 1 cardiology visit follow-up. So it's important, but I don't put a ton of weight into it. So medical provider resources. Great question was asked earlier. What does your on-site provider team look like? So when I say provider, this is a mid-level provider or a physician that's able to write orders on a patient, everything from medications to what their next steps in care are. So we have that covered 8 a.m. to 4:30 p.m. Monday through Friday every week. So what happens when it's not those hours? Well, we have our on-site care team built up of RNs, LPNs, and they utilize a couple different resources. One is NAFCARE's StatCare telehealth team. So StatCare is a team of mid-level providers that are licensed in the state of North Carolina that work in Birmingham, Alabama, our headquarters, and they are at a call of our nursing team. So they are at a desk 24/7. They have access to the patient's chart if somebody comes in at 2 a.m. and presents with 4 or 5 different conditions, and we need urgent orders or we need direction from a provider. That's who they're calling. So that's a cost-effective way to have provider-level resources around the clock that NAFCARE provides as part of your contract. That cost of that is built into your fixed monthly fee, and you're not charged per use of that fee. The second thing we've implemented in order to try to ensure that we're using emergency room services appropriately is our virtual ED service. So ED, emergency department. So in this case, when a patient comes in or when a patient might be in population and presents to the nursing staff and we don't have that provider there during 8:30 or 8 to 4:30, we want to talk to a board-certified physician that's licensed in the state of North Carolina and say, here's what's being presented. The nurse communicates to them, here's what this patient is facing, and then that provider has a conversation using video conferencing with the patient and the doctor makes a recommendation, hey, this guy needs to go. These 3 things make me very concerned, send them off-site to the emergency room. Or it might be, hey, nurse, let's get this medication order on board, let's call me back in 1 hour, I want you to give me a blood pressure, they update them on their care. And the goal of that is to use somebody that's very experienced in emergency medicine and try to use on-site resources before we just automatically send them to the emergency department. So we've had that on board for the past 4 months. And we're continuing to work through training and continuing to utilize that service to try to control costs. The last thing I want to mention, we have a team of corporate specialists in about 17 different specialties that work for NAFCARE, that are a part of your fixed costs, that can be consulted before we just send somebody to cardiology. We can say, let's talk to NAFCARE's corporate cardiologist. Let that person review the chart and provide a recommendation if they truly need to go off-site for that cardiology. So again, these are all items that we're trying to do to make sure we give provider resources in a timely manner. Cost savings effort. A year ago, ACA was our friend in the world of corrections because we had an open enrollment year long. So we could get patients enrolled in the Affordable Care Act insurance plans and then utilize those when they had to go off-site. Now we don't have that option. The enrollment period has shrunk into the traditional enrollment period of, I believe it's November to January timeframe. And so NAFCARE was providing the service, and we will provide it again, but right now our hands are kind of tied. We can't get people enrolled because of the federal enrollment period has shrunk to the end of the year. The second piece is NAFCARE's utilization. It is our job to ensure appropriate utilization of offsite care. And again, one of our big focus areas here is what does utilization look like for safekeepers? We really want to get in the weeds on that and report back to you. COHA letters, complex offsite health. I'm embarrassed I can't remember the last letter. Anyway, this is a way in which NAFCARE communicates to your team about patients that are going to have costly, complex healthcare within the facility. And your county and sheriff's office have been great partners with us in hearing us out. They might have a patient that's has very complex care that is going to be extremely expensive. We communicate that, and then they look and work through the judicial system to see if there's an appropriate course of placement for that patient in order to save costs without sacrificing the safety of the community.
And I will just put a pin in it for a moment because I want to speak to staff to just ensure that we're communicating with the judicial system and they're working alongside us relative to those individuals in the detention center.
That would be with the sheriff's office. I've never seen any of these letters, so I don't know if Mr. Yance or even Major Henson, I see you in the back, how that process is working.
I can answer how it's working. I can certainly look into it.
Can you come to the microphone?
I don't know what letters are. I don't necessarily know how it's working with respect to finances.
Yeah, because it could be very significant. And I say that because if we have a resident in the detention center who has cancer and could possibly go home and be treated, we would rather use that matrix versus what we already have.
Yes, ma'am.
Yes.
Normally speaking, it doesn't quite work that way. What we've done, we had a case like this just recently, the first one we've dealt with since I've been at the sheriff's office.
Sure.
And we worked with a better word, it's a monitoring system company, which is what we're doing now, to see if maybe this will kind of work along in conjunction with this. Say, okay, Gabe is so unhealthy, but he's not this big of a danger to the community.
That's
So we're going to
correct.
put him on electric monitoring and see if we
Right.
can get him out. And we're working on that right now. I think that's what he's
Working.
talking about. Yes,
Yeah,
ma'am.
that's, I
Wait a
mean,
second.
I'm not jumping on you, but I'm just saying we all have to work together. And,
Just a second.
the sheriff's department has made a compelling argument, in my opinion, today, relative to his overtime and why he's where he is, because we're not working together. So I'll just leave that there. Go ahead.
Just given your familiarity with the detention center and the location of the night shift mid-levels, wherever they're located, if somebody up in one of the units has a cardiovascular catastrophe, how long does it take for the nurse or the LPN to get to that patient, given the security precautions that are necessary to administer CPR?
I can't let us qualify an exact time. It's quick. My staff is trained as well. I have not had any issue with response times. It's not, generally it's not immediate unless you're sitting right there when it happens. But at a max, you're talking maybe 3 minutes, maybe. That's from somewhere depending on where I have you coming from.
And they can administer CPR then, including resuscitative meds.
Well, the meds I don't know about. As far as starting the process of CPR, I know that.
Thanks.
Any other questions?
Regarding your question, he's absolutely correct. We do carry a man-down bag. Our staff is notified, and they have excellent coordination with custody as far as getting doors unlocked, getting there, and then AEDs, CPR, all that kind of stuff is a part of our regular practice. And we do drills every quarter to ensure that we can get to the nooks and crannies of the jail just in case a patient does have an adverse event.
What about meds?
Yes, sir. The Go Bag does have critical meds on board, like anti-seizure meds, that kind of stuff. Yes, sir. Insulin, if that's what it is. The last piece that we talked about earlier is responsible party. Let's make sure the right person pays the bill. Sometimes it is the responsibility of NAFCARE. Most of the time it is the responsibility of NAFCARE and the county. But if insurance exists, we have automated systems that help us check that and try to use those, and so that we can be as fiscally responsible as we possibly can. So in conclusion, there's no question that costs have gone up. It's easy to say, well, the ADP went up, and it has, and that is a valid reason. But the bigger drivers are the number of offsites per patient has gone up significantly, and that relates to the acuity, and the cost of care in the community has gone up. So all these factors are compounding. And again, the Safekeeper costs have really been significant compared to previous years, and is an area for continued investigation. So with that, what questions can I answer, Board?
Let me ask this question. Obviously, you deal with jails all over the country. I'm just kind of curious whether there's a possibility, or if it's ever done, that the jail itself has the equivalent of like a hospital room, where it actually it's kind of equipped. And I mean, I know that's a big cost and whatever else, but if I remember right in an earlier slide, the average stay is something like 30 plus days, 38, 39 days. That's a lot of days.
Yes, sir.
And if that's going to be in the hospital, and I'm looking at the cost of, deputies supervising, being there, perhaps in the hospital all that time. Whereas if you had X number of cells that had that capability as a hospital room capability, I mean, I take it that's never happened, that no one is considering something like that.
No, it's absolutely a reasonable question. It's more common in prisons where we have patients that are there for years and years. But some of your major jails, and by major jails, 3,000, 4,000 plus ADP, that's where you start to reach a cost benefit to where it makes sense to do that. The staffing requirements to meet the requirements of like infirmary level of care, that's when you compare, okay, what does it take to have a 24/7 provider here? And nursing that's dedicated to these 15 beds or these 30 beds. So it really does come down to cost, and typically we see that level off around 3,000 ADP to where it's actually worth it.
Got it.
And just a question, I'm not sure if you know this or not. When was the last time that we had a death in the jail?
I need to refer to Sheriff's Office. I know.
I can get you that information.
August last year?
But I can
Relative,
get that.
I know
confirmed
that
for you.
there's HIPAA violations, but relative to was it a suicide or was it,
Yes.
okay, fair enough. Thank you.
Can I ask you another question on a previous slide? It's the one where you're showing, you're getting close, we'll keep going back, just we'll stop there. The virtual ED service, if I'm remembering right, you said that is fairly new?
Yes, sir.
So that's a new item. So you mentioned that the stack care is actually a part of our, what we pay you, costs
sir.
built in. What about the virtual ED service? Is it an additional charge to us?
Yes, sir, it is. It's contained at just over $100 per encounter. And so that cost is considered an on-site specialty care cost. And so the way we look at this is if we're considering a patient in front of us, and they might, if they have chest pain or clear indicators, you get them out the door, right? You're not going to waste time calling somebody on the virtual ED. But if they're presenting to the nurse or provider and like, hey, I think this person might need to go to the emergency room department, that's when we pause and bring in this virtual ED service. And for that $120, they evaluate the patient in real time and provide support or direction. So that's far less costly than, the ambulance ride or the trip, which would easily be a few $1,000s.
And the stack care part is not virtual and is less of the communication that's provided, because it's
You're right.
it's an on-site clinical staff with access to centralized teams. So they're just talking, that's real time also, right? I'm trying to understand the difference between those two,
Yeah,
the stack care and the virtual ED service.
the better way to draw the line between the two is Stat Care supports intake. They're experts at detox, continuing meds when patients come in the door, and stabilizing patients. The virtual ED service is more like, this person just came up to me and said they're having chest pain, how do we need to evaluate? So they've already been in custody. So I think it's easier to draw the line, Stat Care focused on intake, virtual ED focused on general population.
So I would assume from the virtual ED, there probably are some diversions from the ED. In other words, they're actually able to be served
Absolutely.
where they are.
We've
And
seen
that
great
getting
numbers.
started, that could end up being certainly another sort of way to manage that, the cost piece. I've got a question that's really not NAFCARE related. It's really related to the population growth. And I have just a curiosity question. I was just thinking about this after when I was reading the materials this weekend. And that has to do with sort of the average stay of, these are like pre-adjudication issues. So is the pre-adjudicate, I'm trying to get at the capacity of processing, having trials, having this, and folks staying and waiting. And I've heard numbers of, years that people before someone actually gets adjudicated, and they're not yet found guilty of anything, and we're paying their healthcare costs and all these, and their meals and et cetera. And I'm kind of curious about that type of measure that gets kind of back over to the courthouse, to the DA, and to that processing. And is our growth because of extended days, that people are awaiting adjudication, or is our growth because we're just arresting more people? And it seems like that analysis is really critical to the cost part and really relates to the efficiency of how basically the courthouse is operating that impacts us.
Great question, Dr. Martin. That's a broad question, and I'll have to give you a broad answer. Ever since we dealt with COVID, I will say that we were backlogged in the judiciary. So from that point forward, and I do have long stays. I have stays that are up to 10 years right now.
10 years pre-adjudication?
Yes, sir. Yes, sir. I have several.
How could that be?
Well, I only have so much power when it comes to the courts. I can't push but so hard. I will say that in the last 2 months, what we have done, I'm going to use some terms here that we worked out with the courts. We're doing a rocket docket, and what that is the low-hanging fruit, those I can get out, I'm getting out. And that was a collaborative effort between us and the courts. So we're trying to kind of bust that over to the bigger cases, if that makes any sense at all.
I hear
If
what
that
you're
answers the
saying.
question.
Yeah, I've heard that expression, rocket docket.
Yes, sir.
And get it. Wow,
Yes, sir.
that's a wow.
I fully agree. It's something that we have been dealing with for, like I said, 4 or 5 years, and it's not gone unnoticed. We've tried, and I think everyone's doing what they can do. I only have so much push with the courts, and I think they're doing what they can do. But when you have the amount of inmates we're having, and of course some of the changes in some of the laws, You just have a large amount of people in there. And as you well know, 1,016 is what I hold. That's it. And over the last several months, several times we've hit the 950, 960 range. At which point, then I'm kind of having to be real watchful and be real close. So we're trying to do everything we know how to do, and I think the courts they're helping us the best they can. As far as those long extended stays, I can't give you an educated answer. I could try to get one.
Major Henson, what's been the latest conversations on the ankle monitoring to try to help reduce the population in the detention center?
Well, we last week we met with Tar Heel Monitoring, and they're based out of New Hanover County. So, and what this was, to give any, it's a monitoring system just like the Seegent system, which is for the domestic dispute or domestic violence. So we met with them and kind of got an overview of what they have, what they do. Now, some counties put heavy felons out. We don't do that. But what it does, it gives me the ability to say, I'm just using a number, these 100 people who are in here for, let's just say robbery, that don't present, and this would have to be agreed upon with the courts too, don't present a threat. We put them out on electric monitored, and Tar Heel Monitoring does that monitoring. And I'm just using their name because that's who we're talking with. There's several companies. And the main thought of that is if you're out, then you're paying for your food. If you have to go to the doctor, you're paying for that as well. The last situation with the individual that passed with cancer was an eye-opening experience for something I had never dealt with as far as the inmate population, and the courts were not willing to budge because of the charge. So we had to really do some creative thinking, and it started a conversation up to say, hey, maybe this is something we can do with some other things. So that is in the works. It is a heck of a process. You have to have a lot of people, a lot of buy-in from a lot of different people. So that's what we're trying, if that answers the question at all.
Is New Hanover using it?
Yes, sir.
And
New
for a
Hanover.
broader range of,
Yes, sir. New Hanover, Wake
offenses.
County's using it as well. I think, if I'm not mistaken, Captain Surratt, I think Wake County has almost 1,400 out on electronic monitoring of some sort. Not saying they're using the same company, but they have just about as many out as they have in the facility. And Wake is, of course, very large.
You're parking some inmates, or at least recent parties arrested in adjacent counties, though, as well, are you not?
There's a few of those, not very many, but there are a few, yes, sir.
that's helpful. That's helpful.
Any other questions? Did I answer the question, ma'am?
You did, but we had ankle monitoring a long time ago, and then it went away. Was
Yes,
there
yes,
a
ma'am.
reason behind that?
Went away before I was in this position. I think it came down to a funding issue, if I'm not deadly mistaken.
Okay.
I had one question back for the gentleman from NAFCA. You mentioned that you'd been impacted by the change in the enrollment period for ACA.
Yes, sir.
How are you impacted? How are our costs impacted in terms of the detention center?
NAFCA provides or provided a service to where when a patient, it was indicative that they would need off-site care, either being hospitalized or specialty care, typically hospitalized, we would work to enroll them in Medicaid. And
Medicaid or?
Sorry, Medicare.
Medicare or ACA, the market?
The latter, you're absolutely correct. So through the Affordable Care Act, we would get them an insurance policy that leveraged the expansion. And previously, I believe, and somebody will need to verify me, but following COVID, that enrollment period was year-long, so you could constantly enroll patients. And that was extended for a number of years until this year, where they then shrunk that enrollment period back to, I believe it's November through January of each year. So the way that impacts us, I can only enroll a fraction of patients that I used to be able to do on a rolling basis.
Okay, thank you.
Mm-hmm.
If I may, who pays for that? Who pays for their services through ACA?
The act of enrolling the patient,
No, who pays for the plan?
I think it's all a part of the expansion. So Affordable Care Act. So they're signing up for the Affordable Care Act at an income level that allows them to have
Gotcha.
low or no premium.
Gotcha. Fair
Yeah,
enough.
that's a great question.
If there were a premium, it'd be probably more cost-effective for us to be paying that
Absolutely.
premium, and then the insurance would actually kick in at a time if it's ever used.
You're absolutely right. In those
A lot of
cases, we
sense.
are paying that premium.
That's an interesting, another interesting.
I like where you're going, Chairman, with that. So to that thought, you said November?
Correct. I
Could
believe it's
start
November
looking,
15th.
if you had someone there, you could start looking at those patients that you have on your roster and having them apply through January?
We're just going to start in September.
Oh,
We're going to be
September,
off to the races. The second that thing
Gotcha.
opens, we're going to shoot all those applications in and do everything we can. And so
Sounds good.
that's a service that NAFCare provides as a part of our fixed costs.
Gotcha.
And we have an entire team that's all they do. And so we call them blitzes. It's not as fun as Rocket Docket, but it's a blitz of enrollments, and we go hit the facilities and try to get every patient we can enrolled.
Sounds great. Thank you.
Yeah, but there's going to be a lag for the February 1st, inmate that comes in. You're waiting until next November. And clearly, it doesn't appear likely they're going to get adjudicated before then. So
Correct.
I hear you. Wow.
And the laws could always change. Next year, they could come back and say it's year-round again. So it's kind of a moving target on that.
Pretty eye-opening. Any other questions?
Thank you for your time.
Stephen, are you going to close us out? Okay.
Well, first, we would like to say thank you to Byron and the NAFCare team for being here. Again, this has been a very complex situation for us to be able to analyze. And due to that and what's been shared here, that's what's been making the projections so hard to actually get accurate at this point. To the example that Major Henson mentioned, just recently we had an inmate that was in the hospital for almost 2 months with terminal cancer and resulted in a $300,000 hospital bill. But luckily, NAFCare, did their portion, was able to get that amount down to the Medicare level and share those costs. But these kind of unpredictable, high-cost cases have made accurate forecasting very challenging. Because of this, we are requesting an additional $880,000 for this year's contract term and $660,000 for next year. The difference is there because of that $128,000 that was carried over, so we're hoping we won't see any increased levels of this, but we're expecting about the steady rate. This will be a total increase to the contract of $1,540,000. But I do want, and I shared this with the Sheriff's Office, I do want to clearly state and emphasize that these are still conservative estimates, and unfortunately, costs may continue to dramatically fluctuate and result in projection changes. But we wanted to be honest and transparent on that fact. Briefly, because it is the next agenda item, I did want to talk about the food services at the detention center. As it's been mentioned, we are experiencing the higher inmate population, about 8 to 12% of what was budgeted for that contract. We expected a range normally around 800 to maybe a skew high of 850. As it's been mentioning, we've been staying well above 900, hitting sometimes 950, 960. This has increased medical costs, and like the medical charges, there are no internal funds available to cover this difference. We are requesting additional $140,000 for the Aramark contract, which will increase the total 3-year contract to amount a little over $5.9 million. We did recently issue a request for proposals just to make sure we were remaining competitive with those prices for a new 3-year contract, and we will be bringing that to the board for approval in June. In conclusion, we are requesting a total of $1,020,000 additional funding for this year. $880,000 is for medical services, $140,000 for food services. These increases are driven by inmate population growth, higher medical needs, and overall rising cost. This funding is necessary to remain compliant with legal requirements, reduce our risk, and ensure continued quality care and services. And with that, I'll take any questions you may have.
Any additional questions?
I don't have any questions, but I do have some comments, so please forgive my vernacular. I will say this, I don't want to raise hell, but if I need to, I will. And this is for my sheriff because He's not responsible for the crime, but he's responsible for responding to the crime, right? And I'm speaking to our staff here. Thank you for the justification today relative to all of the things that he tried to share with us and that we didn't understand. I understand it more and more today, and I appreciate you guys being here to clarify some things for us. Now we understand. And with that understanding, I'm hopeful that our staff will get to the table with our judges, back with you all, and figure this stuff out. For example, the COHA, the COHA letters, there's some cost savings there. Yeah, I mean, I think that we've all kind of figured out some cost savings and some ways to do that. So again, the expectation is to start seeing that in the future. So thank you.
Yes, ma'am. Thank you.
Thank you.
Agenda item number 20 is a resolution awarding and authorizing execution of an agreement for debt and lease management software subscription. Adam Fernbach, our Treasury Manager, will brief this item.
Good afternoon, Mr. Chairman, Madam Vice Chair, and Commissioners. This item awards a contract and authorizes it to Fifth Asset doing business as DebtBook. It is our current provider for debt and lease management software. And we reached out to them and another provider for this service, but DebtBook is the only provider that covers GASB 87 and GASB 96. And, that's why we're bringing this option to the board.
Questions for Adam? Thank you.
Thank you.
Agenda item number 21 is a resolution awarding and authorizing execution of an agreement with Verinex Corp. To provide endpoint detection and response services to Forsyth County. Michaela Westbrook, our MIS Business Manager, will brief this item.
Good afternoon. This item seeks to award and enter into a 3-year contract with Verinex Corp. to supply us with SentinelOne cybersecurity for our roughly 2,700 workstations at a total cost not to exceed $419,352.67.
Any questions for Michaela?
Thank you.
Thank you.
Agenda item number 22 is a resolution authorizing execution of a lease agreement with Winston-Salem Forsyth County BMX Parents Association, Inc. for the lease of county-owned property located on a portion of Tanglewood Park. Constantine Stamati from our Parks Office will brief this item.
Good afternoon, Commissioners. Thank you for the chance to brief on this agenda item. As the County Manager said, this item represents a resolution authorizing the execution of a lease agreement with Winston-Salem Forsyth County BMX Parents Association. It concerns the leasing of our BMX track, which with surrounding areas around the track constitutes approximately 3.6 acres of county-owned land situated at 4061 Clements Road within Tanglewood Park, or more specifically, the parcel is located in the south western corner of the park. In terms of purchasing process, we advertised a request for proposal via City County Purchasing. We also advertise it on our social media platform. As a result, we received a single proposal from BMX Parents Association, which is the same operator that has been operating the track for the past years as well, actually a few years. A few key elements of the agreement include Forsyth County will receive an annual leasing payment of $2,800. The lease term is for 3 years. And to align with market and economic changes, the agreement specifies that the annual rent shall adjust in accordance with fluctuations in the consumer price index from the preceding year. The property in question is not needed for county purposes during the term, and the 30-day notice typically required for such leases has been published accordingly. And with this, I'll be trying to address any questions you may have.
Any questions?
Very basic. I'm sorry, the BMX, they're the non-motorized.
Pardon me?
The BMX is non-motorized bicycles.
Yes.
Yeah, okay.
Yes.
Want to make sure my
That's correct, yes. Just
acronym was up to date. Thank
fancy
you.
bikes.
All righty, thank you.
All right, thank you.
Agenda item number 23 is a resolution authorizing quantum merit payment to Neighbors for Better Neighborhoods. Sharita Sutton, our Assistant Public Health Director, will brief this item.
Good afternoon, everyone. We are seeking approval for the quantum area payment in the amount of $41,230.25. As you may recall, we have contracted for Neighbors for Better Neighborhoods, or NBN, to provide evidence-based violence interruption since October 13th, 2022. The program was initially funded jointly by the city and county using ARPA funds. As ARPA funding ended and with data to support positive outcome, services were extended into FY26. The carryover funds were believed to be sufficient to cover the first 3 months of FY26. However, a calculation error in the amount of $41,230 was discovered. A portion of the contract is eligible for reimbursement through AA 117. The state has authorized the use of these funds to cover this amount, contingent upon the availability to support these services through the remainder of the fiscal year. We appreciate your consideration. Any questions?
Can you help me understand this just a little bit better about the discovery of the 41,000? I mean, is this a monitoring issue? I'm looking at this as a Neighbors for Better Neighborhoods, kind of their monitoring of their expenditures, and then our sort of checking and whatever. I mean, what happened to create, that's a fairly big error.
Yes, so in May 2023 and October 2023, there was an overpayment. We overpaid the Neighbors for Better Neighborhoods. They did reimburse. However, when we went to do that was found from the ARPA, from the FY26, when they were doing their audit, they found that in FY25 as they were getting ready to prepare for their budget. And so this also transitioned over to public health. And so when we had our budget that was set aside, we had to do that 65, as I stated, we had the 65,000 that was rolled over from the city. However, a portion of that 41,000 had to be taken out of the new budget that was set aside for NBN. And so that made a shortfall for us in that new budget. So that's why we're requesting that 41.
Any other questions? Read part of that.
So Sarita, what I'm hearing from you is that they don't provide us an invoice and then we pay, or we pay them and you found it through the invoice?
No, we paid them. Yeah, we pay them on reimbursement. So this is something that we found. Yeah, we found that we overpaid them, and then we had we had to come back and deduct that from the new budget that we had, but they repaid everything.
Okay, thank you.
Okay, thank you.
Agenda item number 24 is the resolution accepting the highest offer to purchase county-owned real property by negotiated offer, advertisement, and upset bids procedure for 3325 Silas Creek Parkway. Kirby Robinson, our Community Economic Development Director, will brief this item.
Thank you, Madam Manager. Good afternoon, Mr. Chairman and Board. I appreciate the opportunity to be back with you today on this item. You'll recall Amos Cottage is located at 3325 Silas Creek Parkway, 3.2 acre site, roughly 40,000 square feet of improvements there. If we step back in time, almost a year, in summer of 2025, you directed the manager to solicit offers for the purchase of that property. In September of that same year was when the atrium lease ended for Amos Cottage. So the property then was vacant at that time. In November of that year, we received a letter of intent from Jim Cap Development, and that was for a purchase price of $2,025,000. And that started the upset bid process the board approved. Between December and February now of 2026, we received 4 separate upset bids for that property. But the last and highest offer was submitted by Jim Cap again at $2,662,850, which is a $637,000 increase from the initial offer. We have negotiated a purchase and sale agreement with Jim Cap, which is attached to your item for review today. Just a quick couple notes from that. It really follows a lot of the Sturmer Park model that the board previously approved. You have a due diligence period of 120 days. They can extend that for 2 30-day periods. If they do, they have to deposit an additional $12,500 per extension, which is non-refundable. After due diligence expires, you move into a permitting period. Again, it has the same terms, 120 days of permitting, 2 30-day extensions. $12,500 per extension is due, and those are non-refundable. Closing is 30 days after the expiration of the permitting period. And just as a reminder, the buyer can terminate the purchase and sale agreement through the permitting period, but the deposit is not refundable after the expiration of due diligence. So I think it's a pretty solid contract. We're excited with the results of the upset bid process and happy to bring those before you today. Happy to answer any questions the board has.
Any questions for Kirby?
Thank you.
Thank you.
Agenda item number 25 is a resolution authorizing the grant and execution of a temporary construction easement to VNC Land Company, LLC, across a portion of Forsyth County-owned real property. Chelsea Swaim, our Deputy General Services Director, will brief this item.
Good afternoon, Mr. Chair and Board. This item is a request for a temporary construction easement from VNC Land Company, LLC. And as you know, they are in the process of acquiring a 3.5-acre portion of property at 5580 Sturmer Park Circle on the corner of University Parkway and Chatelain Road. And they need this temporary construction easement in order for them to do some of the necessary land grading for their development on the property that they are purchasing for us, as well as they will be installing some landscaping along our property. The temporary construction easement is 16,657 square feet, and we have checked with staff, and they do not see any issues or interference with our property. And once the temporary construction easement is terminated, our grounds division will begin maintaining the landscaping that is installed. Happy to answer any questions you may have.
Good. Any questions?
Yes. Will the temporary easement entail removing any mature trees on the section that they're not purchasing?
It's possible, but I don't think that had really been contemplated very much. We had really just wanted them to add some shrubbery and some landscaping. If there's something that needs to be taken down, we have not pinpointed that yet.
Well, would you check on that before Thursday? I'd like to know before I vote on this.
Absolutely, yes, sir.
Thank you.
Other questions? Okay, thank you.
Agenda item number 26 is Chelsea's as well. It's a resolution authorizing the grant and execution of an easement to RSPD Riverwalk LLC across a portion of Forsyth County-owned real property.
This is a request for a permanent and a temporary construction easement from RSPD Riverwalk LLC across a portion of property at 0 Tanglewood Park Road. And this is needed for, to comply with the rezoning of RSPD Riverwalk's rezoning application of their property that adjoins the Tanglewood Park property. And it is for the installation and maintenance of a brick wall, which was, again, a requirement of the rezoning. And they are unable to install that brick wall on their property because there's an existing sewer line, and the footings from the wall would interfere with that sewer line, so they need to cross over into our property to construct the wall. This would be on the 14th hole of Tanglewood Championship Golf Course, and it's not very far over the property line, about 1 to 2 feet, just depending on where you are. And then the permanent easement would be 18,505 square feet. And the temporary construction easement would be 8,593 square feet. And they are proposing a compensation of $16,012.48 for both the permanent and the temporary construction easement. And tax staff have reviewed that offer, and they did not disagree with the methodology that was used for it. And we have checked with the park staff, and they do not see any issues with this. And then, of course, Riverwalk would be required to maintain the wall per the terms of the Exhibit B that is attached to the easement. Happy to answer any questions.
Are they the ones, the price, are they the ones that submitted that?
Yes.
Well, I'd like the staff to take a little bit of, little work, but Kirby will help you if you need him. And other staff that's well qualified to determine the square, all of the square feet that you're talking about is at least equal to the, you may have to do some mathematics, and if nobody else can do it, I've got somebody right here that can do it. Chairman can do that if nobody else can, but I'm confident somebody can. but at least comparable to a rate that was paid for the property.
Okay.
And if it don't, I know it'll take a little work to do that, but
Just for my own clarity, the paid for the property that Riverwalk owns or paid for the Tanglewood property?
well, the value that I think you would use what Riverwalk paid for property that they bought.
Okay.
And make sure that this is at least equal. You know, if you have to work it out by the square foot, just work it out by the square foot. Over there at, where's Planning Man? How much was, Chris, if you know this off the top of your head, over there at, and this has been a few years back, Lowe's over on, I don't know the street they're on the west side over there. So some of them properties are over there, how much they sold for square foot. You don't remember that? Well, it was like, it wasn't by the acre or half acre, it was square foot. But just, if you would please do that, I would like to know.
Yes, sir.
Variation of the question I asked about the Sturmer property, you know, you can have the aesthetics of the course can be impacted by, you know, removal of mature vegetation. Can you check on whether any of that?
We do very much anticipate there to be some trees removed for this easement, and in talking with the Parks Director, that would not negatively impact it. That would actually probably benefit us.
Okay, thank you.
Got it. Any other questions for Chelsea? Thank you.
Agenda items 27 through 29 are our reports. 27 is the ARPA disbursement status report, 28 is the March financial report, and 29 is the March contribution-based benefit cap report. That is all of our agenda items. We have one closed session motion.
Could you read the motion for closed session, please?
I need to ask the board to consider a motion to go into closed session to discuss a matter relating to the location or expansion of industries or other businesses in the area served by the public body, including agreement on a tentative list of economic development incentives that may be offered by the public body in negotiations pursuant to the provisions of North Carolina General Statutes 143-318.11A4. And since there's no other business to come before the board at this meeting, following the closed session, the meeting will be adjourned.
I make that motion.
Second.
Second by Vice Chair Wizenhut. Any discussion? All in favor, please say aye. Aye. Motion carries unanimously, and we are adjourned.